All right, everybody, we're live. You can tell I am hosting today because there's no fancy intro music because I have no idea how any of this tech works. I just see the giant go live button in the top right-hand corner, and that's all I know how to do. So welcome back. It is myself, Dr. Brad Dieter, and we also have Dr. Mike Stair, who is a fellowship-trained physical therapist, and he owns Orthopedics Plus and Spectrum Fitness Consulting, and he is the East Coast aficionado of all things physical therapy. And what else? What other like random talents do you have that we need to know about?
Random talents. I'm pretty good at doing ponytails and pigtails on little girls, having 3 girls.
Hey, that is a good talent.
I'm quite dominant in ping pong. So, but it has
Are
to
you
be late.
really?
It has to be late at night, and there has to be a couple beers involved.
You know what's funny is that's like at this point in my life, that's probably my favorite sport / activity.
I love it. I absolutely love it.
My neighbor's an ER doc, and I just like ride my bike down there and we play ping pong in his garage.
Are you one of those people that stands like 7 feet away from the table? Because
okay.
Oh, yeah. All right. I haven't quite got to that level, but
so yeah, we play pretty hard, but it's a ton of fun. So, well, I did not know about that. Now I know what to send you for Christmas. ping pong gear.
Right.
Awesome. Well, Mike, it's great to have you back. I always really enjoy our conversations, even if we have like one listener today. I know I'll really enjoy it. So, today we're talking about kind of osteoporosis, musculoskeletal health, more on the skeletal side, and then we're also going to talk a little bit about foam rolling. So, I think probably the first place to start is just kind of a discussion of bone tissue, kind of like what is it and why do we see such a risk of kind of osteoporosis or osteopenia in kind of today's society?
Yeah, well, I think the first thing to highlight that it might not be common knowledge to any trainee, let alone older or younger trainee, is that bone, just like any other tissue, and perhaps even more so than any other tissue, it remodels, it grows, it responds to load. And that remodeling process happens, of course, with, injury and pathology, but also with normal functioning. So I think we have this idea that it's some scaffolding like steel or wood, and it's relatively inert, but it's incredibly dynamic. It even bends, in normal function. So it's an amazing tissue, and it responds brilliantly to training. So I think that's the first major point, about bone. And the second, because I think people tune out when they hear bone density or loading of the bone, is that it's something that is not just to be done for people with osteoporosis, osteopenia. That is usually where people, mostly females, as they get right around menopause, they start getting their T-scores and they start getting tested. And somebody brings up, oh, you have osteopenia, which is the earlier form of osteoporosis, which is a more extreme form. And then they start thinking about it. I have 3, young daughters. This is where I actually encourage people to intervene. Your ability to build bone is far better when you're younger, and your peak bone density occurs between about 25 and 30 years old. Some maybe even younger when they're, especially in females. So the time to build the tissue is in the adolescent periods.
And so in terms of doing that, I know that we can talk maybe a little bit about how we kind of slow decline, but in terms of building it when you're young, how much of it is load dependent? Like how much do you actually have to overload kind of a young skeleton to make it grow versus is it just kind of having adequate nutrition and then hormonally which one of those two is kind of the biggest driver, or are they pretty similar?
Well, as far as from the hormone standpoint, most of that, the dosage issue is in terms of studies is in older populations. In younger, it's more correlational.
Yeah.
They see people that did running and jumping sports tend to having better bone density, but there hasn't been any interventional studies that I know of in younger populations. In older, there definitely is. The reason why I think load seems to be the primary driver is They've done studies in older adults where they've had those with hormone replacement therapy plus vitamin D supplementation plus resistance training, combined with a group that and this is a really interesting study, by the way, because there's many people that are ineligible for hormone replacement therapy.
Mm-hmm.
So the comparison group was just resistance training and vitamin D supplementation. And they had almost equal results. There wasn't a significant difference. So I don't think the hormonal variable is the primary driver. Certainly it's a factor. So I think we could go to load and nutrition. Nutrition without load has not shown to significantly improve bone density. So I think the main variable then seems to be load. Obviously, I think we want to make sure nutrition is a component. Calcium and vitamin D seem to be the biggest components when it comes to nutrition, but nothing interventionally I've been able to see that parses them out.
Okay. And I guess a couple questions. So in terms of the loading, I think one of the things that and you mentioned this a little bit just a second ago, but I think canonically most of us think of loading of like, hey, put a bar on your back and squat and deadlift and do things like that. But I think the other thing that you brought up, which I think is important and a question I would have, is kind of the jumping, running, landing, kind of really quick, like load sports. Which one do you think drives a bigger, like, hey, we need to adapt signal? Is it kind of the higher impact type of loading where it's like quick, very high load versus kind of, heavy load, but that isn't that big of a load compared to what like a jumping landing would be?
Yeah, that's a great question, and I'm not sure that we have a perfect answer that again parses those out. But there have been studies that have shown the contrast between loading and that includes relatively continuous loading, so higher repetition, constant tension versus peak loading. Not a lot of amount in terms of time of load, but the intensity is relatively high. And that's very consistent where they're finding that peak loads that are beyond 70, upwards of 90%. One study I'm aware of did compare doing resistance training versus resistance training plus impact loading, like drop jumps. One was a really interesting one because it was the average age of the participant was 68 years old, and they had him do jump chin-ups, which is pretty cool, right? Yeah. They jump up to the chin-up bar, and many of them couldn't do a chin-up, and then they dropped from it. So it was kind of a combined strengthening impact. That group did significantly better than people that are doing relatively good strengthening exercises. I mean, they were doing lunges and they were doing squats and dynamic movements. So I think that the synopsis of what I'm seeing, impact matters and magnitude of the load matters. And most studies I've seen, there is a direct correlation. The higher bone density correlates with a higher amount of load.
And would you say that's probably one of the things that we get a lot less of as we age? Like I think about what I used to be, I don't know if able to do or like was willing to do when I was in my teens and 20s versus in my 30s, like jumping off of a box, like a depth jump. When I was 20, I was like, oh, that's no problem. And then in my 30s, I'm like, I don't really want to do that. That's pretty uncomfortable. Yeah. And so just how much of that do you think we do less of that as we age?
Totally. Yeah, we definitely do a lot of that. And, what's interesting is that these conversations, as a physical therapist, as well as a trainer, it's kind of like, what's the ideal program? It's that type of conversation to get into. We could talk about what the ideal program is, but most of my clients can't do it. They're too busy. They have too many restrictions. So is, drop jumps, is impact loading better? Yeah. The problem is that a lot of people can't tolerate it. That's why I started out with that emphasis that's why we need to do that in our teens, in our 20s and the 30s, because you're right. I'm 45. When I want to do jump squats, I do it in the yard as opposed to on the driveway. Yeah. Or I like doing the box jumps because I like jumping up on the box, but I don't like coming down.
You just very nicely stand off the box. Yeah,
Yeah,
that's exactly what I do.
Right, exactly. If I could jump in a pool afterwards, I'd be even happier. But so that being said, jumping jacks are a form of that. I mean, you can have some micro, loading and prepare for it that way. But getting stronger does help that part out.
Yeah, and so one of the really interesting things that I think a lot of us, including myself for a long time, didn't really understand is when we think about like the weight that we're lifting, right? The amount of weight, like let's say you're doing a back squat, the amount of weight that you put on the bar, let's say it puts 200 pounds of, force on your back. The muscle contraction and how much force that puts on your joints is much higher, right? I mean, I think it's in the neighborhood of, depending on the joint, 5, 10, 20x what the like Newton force is at the joint.
Yeah.
So are there ways or are there exercises or are there kind of things to do that you can get that kind of bone loading from just like the force of, axial loading on your bones without huge amounts of weight, just from kind of, being smart with the way you program exercise to get high joint forces without a lot of like joint torque, if that makes sense?
Yeah, absolutely. And I think another way of doing that is isometrically as well.
Yeah.
That's why, farmers carries, for example, asymmetric farmer carries. We see this tolerated brilliantly by older adults, and they definitely see the utility of it. Holding on to a dumbbell on the right side, the contralateral force of the left obliques, let alone the lower trap, trying to stabilize while they're walking, that's reminiscent of things that they have to do around the yard. And that's a huge fleeting notion of independence, when you can't take care of your own home, that many 60, 70-year-olds are wrestling with. So that's an example of that. Maybe their knees can't tolerate, heavy trap bar, deadlifts. Certainly their shoulders can't tolerate getting their arms back to hold on a squat, but that would be an example. Another is doing things like prone on the ball, reverse flies. They can't deal with the hyperextensions that are common in, let's say, the 45-degree hyperextension or a lot of the more advanced ones. But holding that position when their body is counter-levered over, the roll or the ball, the extensors are working pretty hard. There doesn't need to be a lot of external load. You move your arms away from your waist, bring it out to the side. It's a challenge to the, to the rotator cuff, the scapular muscles, but the paravertebrals are working pretty hard there as well. Obviously, it depends on the ability. But one example I like to tell people about is, for example, lat pull downs. The reason why I love lat pull down so much is that one of the areas where there's a highest loss of bone density is the lumbar spine in older adults. There's obviously the hip, and it's much easier to load, the femur, with lunges, with squats, with step ups, and all the other progressions. But it gets harder if they can't hold on to a lot of weight through their skeleton, through their spine. The thing about the lat pull down is because the lats have an attachment down through the thoracolumbar fascia directly on the lumbar spine, the loading, the tensile force of the lat can actually load the bone. And you can incrementally load lat pulls from 5 pounds to 105 pounds to 200 pounds. So for other reasons, it's a great option in exercise. But I find that's a forgotten option when we're thinking, well, my client's having a hard time, or whomever is having a hard time with the traditional lifts. That can be a really good option too.
Yeah, that's whenever I do lat pull downs, like the next day, I always feel it in my back, like my low back. That's generally where it gets the most sore. That's interesting. So in terms of, we talked about this a little bit, and I've done quite a bit of kind of reading on the whole vitamin D bone thing. What is your kind of view of vitamin D supplementation for either, preventing osteoporosis, correcting osteoporosis? And then I guess the other corollary questions to that would be, what are your thoughts on the efficacy of some of these like pharmaceutical high dose drugs that are supposed to stimulate bone growth? Because I know that's also something that has become more popular in kind of the orthopedic circles, is some of these biologics, these injections that they give people.
Yeah. So with the vitamin D thing, you'd probably know much more about this than I in terms of the research on it. As far as what I'm aware of, it doesn't seem like there is an upper limit, like a lethal dose. And every time I'm talking with a primary care physician about a result of a dihydroxyl 25 test, and they're talking about the pros and cons versus having a higher daily dose versus a monthly mega dose. That was something that I actually was on. I was on like 50,000 IUs once a week. There's some, you might be able to speak more to that. It doesn't seem like the recommendations are going down. The trends I'm seeing all the time is that probably a good idea to have a little bit more. And I haven't found a mechanism by which there's like vitamin D toxicity. So I'll defer more to you on that one, but those are the things I've been learning about. What I found also about the Fosamax and the other type of biologics, there have been a lot of side effects that many people have had. And I'm working with a client now that has severe osteoporosis, and she's elected to, in consultation with her doctor, or actually her daughter's a doctor as well, to decide not to be on it. And with resistance training, she's actually within about a year's time, even though she's in her 60s, late 60s, seeing her bone density improve. And we're seeing a lot of cases like that. One other really interesting point about the biologic I'm seeing, many people are being presented as an either or choice. They're giving a false dichotomy. Yeah. You should consider, the biologic, or you should consider doing resistance training. And it's a mentality that I have seen across highly intelligent, well-educated, very informed people. I don't know what it is. I don't know if the psychological effect is saying, well, I could just take this pill and that will affect my bones. And they're squeamish about resistance training. That probably also, it's just not emphasized nearly, even remotely enough by well-intended, primary care folks. So just a little interesting thing I've been noticing on that.
Yeah, and I know that there is pretty substantial side effects with some of those kind of biologics. Is there any real evidence for substantial efficacy for those?
Well, I haven't seen evidence in which they have done a interventional study comparative to resistance training.
Yeah.
To me, a comparison of a control group and a medication group and seeing what the effect is, it's useless, because why would you not want them to be doing this? Because of, even if it didn't improve bone density, the fall risk prevention aspect of the same protocol loading, not to mention the multi-system, improvements, would be a benefit as well. So that I haven't seen, and I don't believe there are any studies that have shown a comparative effect. So that would be, I think, more interesting. But as far as the others, the evidence isn't great.
That is interesting. I mean, it's one of those things where I would say I probably know very few people who've had any success with kind of those biologics. So yeah, the vitamin D story is very interesting. Here's kind of my synopsis of the literature, and it comes from, a lot of randomized trials and a bunch of meta-analyses. Is there's kind of two major things to consider. One is, what type of population is it in? We do know that kind of like community people, so people who live in like the normal world, versus kind of adults who are in, hospitals or long-term care facilities, etc. The people who are in some of these kind of long-term care facilities, things like that, vitamin D supplementation does appear to reduce like risk of fracture and increase bone mineral density amongst that population. Amongst community kind of free living people, there doesn't appear to be a huge benefit of just vitamin D supplementation. the people that there is a benefit is there are people who are pretty vitamin D deficient and who take a relatively moderate to high dose every day. So even like the once a month or once a week super high doses don't appear to be better than kind of daily supplementation of 1,000 to 5,000 IUs a day, which is interesting. And part of my thoughts are the kind of lack of really robust effects is that yes, these people are probably not getting enough vitamin D, but without the adequate signal to your bone to repair, you're just giving it kind of the raw substrates without any reason for it to do anything. So that's kind of, at least from my read of it and kind of what we've seen so far.
Yeah, and have you seen anything about the different supplementation notions of having the daily supplementation? So as you mentioned, like the 1 to 5,000 I use versus having a blocked dose, like a once a week dose.
Yeah, the daily appears to be superior. I think in every study that I've looked at, that it appears that the daily supplementation is better than kind of the bolus dosing. What's interesting is that also appears for some of the other outcomes of vitamin D. So like upper respiratory tract infections, some of those things, the daily dose also appears to be more beneficial if we look across most meta-analyses. So
yeah, it's one of those things where I mean, it's hard to imagine a scenario where you don't have vitamin D. It's like, like, I got enough of that. I don't need it,
Yeah. Which it'll be interesting to see how we evolve over the next, if we're around after 2020, the next, maybe million years of maybe our physiology changes to where we're like, dude, these people never go outside. Vitamin D is a necessary thing for them, but they're never going to get it. So we're just going to change your physiology to where vitamin D doesn't matter anymore. Right. That'd be interesting if we evolve that way.
Exactly.
Any other kind of thoughts, topics on kind of bone density or things like that?
Yeah, the critical thing that I think is missed by the general population on this is that load matters. I can't tell you how many times I hear people saying, yeah, I get it. I know, it's really good to do resistance training for my bones. And they almost always mimic or show me, I do weights all the time. Yeah. And I'm like, no, that's not what we're talking about. The humerus, your elbow is not usually the biggest source of bone density problems. It's like saying it's really important that you work on a lot of reading. Like, oh yeah, absolutely, I do Sudoku puzzles all the time. It's like different subject. Yeah. So I think that needs to be clarified a lot, and the magnitude of the load. It's what I call a load differential. So if you've never done resistance training, doing just bodyweight squats may be enough to facilitate some bone density. If you've been doing resistance training for a while, you're going to need to add a decent amount of load in order to see improvements. So that's what I mean. The load differential, the differential between what you have been doing, what you're currently doing, is probably what best triggers bone density. And studies are very consistent on this. It's hard to see meta-analysis in multiple different sources of studies agreeing on dosage. I think you'd see the same thing in the strength conditioning and fitness world. When it comes to bone density, I see the same thing over and over. Loads that are between 70 and 90% or more, and that usually amounts to about a 6 to 8 rep range. And the coolest part of this is that this is tolerable to geriatric patients. As older than 85, one study showed. So actually 2 studies have shown that I'm aware of. So I think we're way too fragile with, or I should say conservative with our older adult population and even younger populations. For the sake of improving bone, you need to do some heavy loading.
And one of we talked about this a little bit earlier. I just kind of wanted to chat through some of these things too and some of the implications. So if kind of our adolescent years, kind of teens to 20s is kind of our peak bone building time in our life, what is the risk for eating disorders amongst, like teenagers and then kind of their adult life, right? So if we think about people who have, anorexia, bulimia, or they're severely underweight and they kind of go malnourished through their teens, what is the risk of that in terms of long-term osteoporosis? Does that put them at a pretty high risk for, not just then, but kind of over the longer period of time?
Yeah, I'm not aware of any evidence on that. That would be a really interesting thing to do a deeper dive. That would be a phenomenon of catch-up growth, for example. They've shown that from early adolescence to late adolescence, for example. But whether adolescence to late adulthood, we're not sure. We do know that there's impacts, for example, on fertility. That has been a risk factor. But I don't know. I think the logic would add up that it would be you couldn't fully recover all those capacities. Just in the same sense, if you've never done resistance training ever in your life, and then you started when you're 50, you probably going to have less peak bone or muscle mass that you would attain by 60 than you would had you done it all your life. But no, that would be an interesting study or route of investigation to look into.
Yeah, that's always been one of those things. It's always interesting to see, what we do young in our life. How does that, translate long term, and how robust is the human body over between 20 and 40?
Well, you know what I think would be, I totally agree. I think that would be fascinating, especially at the stage I'm in at my life with, 3 girls that are teenagers or preteen. But I think even more of an amazing study is how in the hell would you convince them?
No idea.
Yeah. And I think if you would be able to convince them, the answer would be it's not going to be the parents, because there's a certain point where you become an absolute abject idiot and you don't know anything. So I'm approaching that territory.
Isn't it funny how like you can even look back at your own childhood and be like, you remember the phases of like, oh, you thought your parents like the greatest thing in the world, and then you're like, I don't want anything to do with them, and then in your like early mid 20s, you're like, I just want to hang out with my parents all the time, and then it ebbs and flows like that.
Yeah, I'll never forget when I was early in my career, I had my 2 mentors that I just thought were absolute geniuses. They brought their kids to me to work with them in physical therapy and in conditioning. And I'm thinking, what the hell? They know it more in their thumb than I know. Why would they trust me to work with their kid? And they told me, and said, one day you'll understand. They won't listen. And it wasn't who knew more. It was, they're not going to listen to me, so they'll listen to you. So,
Yep. Yeah. So next question we'll move on to is the very hot button topic of foam rolling. So I guess I don't even know where to start with this other than kind of giving you an open floor. Is, one, I'd be interested to know, what is the history of foam rolling? Like, is there a history behind the science of foam rolling? How did it become popular? And then does it work, and what is it actually doing?
Yeah, that first question is pretty interesting. I haven't thought about that. Ever since I've been in the industry for 25 years, foam rolls have been around, I would imagine, massage has been around for, ever. And I think as people became more interested in mainstreamed, I think, into performance and fitness. I mean, performance and fitness, you should only be if you're an athlete. And, I remember in college, people were doing plyometrics. I'm like, what sport you're preparing for? Like, I just want to get a higher vertical. I'm like, oh, cool. I don't think that was being done commonly in the early 90s or before. So I think people may have been more interested in recovering from intense exercise and massage. And then like, I can't go see a masseuse all the time. But I don't know where the whole foam roller thing came from. That's a really good question. Do you have any theories on that?
I have literally no idea. Like,
I'm now irritated. I haven't thought of it, and now I'm thinking, I got to investigate this now.
So in 2 weeks we'll have an answer of it. Okay.
All right. We're going to have a history of the foam roll, and it's going to be with pictures, of evolution. At first, it's going to be like a rolling pin that you see in a kitchen, and then there'll be some evolution from that. That's always the next question. Yes, is always where I start. It doesn't work. Is it effective? Well, when we say it works, what do we mean? We mean work. Some people think that the goal is to increase range of motion. And then there's, of course, a sub question, is that even important? I mean, do we need to have a temporary improvement in range of motion? So there's some evidence that it does improve range of motion, and the only evidence that we have is that improvement is questionably significant. Questionably because how much is it significant that you can improve your range by 8%? Is that going to make a difference or not? Statistically, then yes, it's significant. How long does it last? It doesn't seem to be permanent. Obviously, that's why people do foam rolling more often. The other efficacy question is, does it help reduce soreness? There does seem to be some evidence that it does reduce the perception of muscle soreness. So foam roll, they do a pre and post test of tissue sensitivity to various amounts of noxious stimuli. The tolerance to noxious stimuli is greater after foam rolling. Again, significance level can be debatable. So it does seem to help for that. Performance, a meta-analysis was just done in 2019, I think, and the performance improvements, again, were questionably significant. One study showing that doing it before had a very small increase in sprint performance. I think it was like 0.7%. And when it came to jump performance, a very insignificant decrease in jump performance, and a very mild improvement in strength performance. So I think the summary of it, from what I've been able to gather, it doesn't negatively. That's probably the best thing that we found. Doing foam rolling prior to exercise doesn't negatively affect performance. It was theorized, like stretching, that it could decrease performance. There's not strong evidence that it does. It may have a slight improvement, but not significant. And it may have a slightly significant improvement of range of motion and subsequent muscle soreness. So
essentially, it's maybe a net neutral tool in terms of like hard outcomes, but there's probably, some psychological benefit of like if it makes you feel better, etc.
Yeah.
So in terms of that, basically, if people want to foam roll, they can. If they don't want to, they don't have to. In terms of like benefit, in terms of like hard outcomes. Now, from like an actual like mechanical physiological perspective, what do we know about what's going on with a foam roller?
Yeah, and that's a great question, and I find it fascinating because I've looked into this a decent amount. My intuition was, there's, how the hell can you be influencing tissue by just pressing on a piece of foam? And before I get into what I found, this was an interesting debate. If it is placebo, if it is that's the mechanism, are we doing much good for people by exposing what the mechanisms are? Because if it's placebo and we're telling people, well, it's just placebo, will we be negating its perceived benefit? It's a weird thing that I'm wrestling with. Does that make sense?
Yeah. So basically, if you negate the placebo effect, are you doing harm by telling them that? What's interesting is there have been placebo studies where they tell people it's a placebo and they still get the placebo effect.
Interesting.
Isn't that wild?
That is totally wild.
The human brain is just bizarre.
I know. It's funny you mentioned that, because I've been wondering, bless you, I was wondering if I should be telling people like, well, for example, I know you're trying to lengthen your tensor fascial lata. I know you're trying to lengthen. Like, there's no freaking conceivable way that that's happening. I was looking at some evidence on this, and it took me a while to find the original source, but I found it last night. The fascial lata, in order to deform it by 1% of increasing its length, you would need to produce of a normal load, which is a direct perpendicular load, of about 8,359 newtons, which translates to 852 kilograms. Or
That's basically like a car.
Yes, you would have. It
Like
would have
a
to
light
be
car.
right. You'd have to lay on the ground and slowly back a car up over your thigh. But that's not it. If you wanted to do a transverse, separating the layers versus down, you would only need 424 kilograms of force. So
okay, that's still quite a bit.
yeah, and they also did it on the plantar fascia, and that was pretty similar. Actually, no, I gave you the numbers for the plantar fascia. For the tensor fascia lat, it's 925 kilograms of normal load, or 860 kilograms. So there's no possible way that we can physiologically apply such a load and cause a deformation that would be meaningful. The only reason I think that's good to know is that if that's what you think you're doing, and your logic is that, well, the more the better, it's worthwhile that I put this much force or this much time into it. I would be able to save somebody the potential unnecessary pain or time by giving them that information. So I'm not shy about telling people that. The idea about breaking adhesions, I don't think that makes sense. I don't have any evidence on it, but if you're looking at fascial layers and you're trying to break the layers of fascia, I don't know how a broad-based application of load distributed over a wide base would do that. It would be a compressive load in that instance, not a transverse load. So I don't think the mechanism there makes much sense. I think we have good evidence that it's more of either a counter irritation, so two competing noxious stimuli drowns each other out. But there is some good evidence that it seems to be more of a placebo. You want me to get into that, or did you have another question on that?
No, yeah, continue. I've got a few other questions, but I'll kind of ask those after we flesh this out.
Yeah, so this is pretty cool. So this study was done a while ago, like 2007. And they essentially were going to put people's hand in like really cold water. And that was going to be the counter irritant. And then they were going to give people a noxious stimuli. They told one group of people that the putting their water in the cold, or the hand in the cold water would make this pain stimuli much, much less. So that was the analgesic group. The other group, they said, it's going to make the pain a lot more. And what they found is that the normal distending input that would come and inhibit, that would happen from the cold water group that would inhibit the pain perception, didn't work in the pain expectation group. They found that it overrid those descending inhibitory signals. In essence, they said, no matter what, even with people primed with the expectation that this is going to be painful, it made it painful. And I think it was like 77% more painful.
A lot.
Yeah. So the point being is that I think by people priming them, say, hey, this soreness that you're going to get from riding this foam roll here, that's going to be good. That's going to be reducing your soreness in your muscle. That's going to be lengthened tissue, whatever explanation you give them. By experiencing that may be the expectation phenomenon, or essentially the placebo in full action. So that might be how it's working.
And so with that, if it's like, let's say you do have, like some, one of the big things that I remember is like, if your knee hurt, just roll out your IT band, right?
Mm-hmm.
So if that mechanism is sort of like kind of overriding some pain stimuli or kind of changing the way you're experiencing it, is it really doing anything to structurally change like what's going on at kind of a distal joint, or is it really just kind of changing that whole pain perception?
Yeah, well, we only have the change in the pain perception as a process of elimination, because we know that we're not causing any deformation of tissue. And even if we are causing deformation of tissue, we don't have any evidence that that's going to affect the knee mechanics significantly. So there's that. I think the best assumption we can make, if there is a positive outcome, it's because of what you suggested. somehow we're changing the pain perception. And that shouldn't, by the way, be minimized. If that does it, then great. But I think it's important that we don't get too mechanistic about it, because we don't have good evidence that that's what's happening.
You brought up something else, and I asked because there's a little bit of my own interest here. Is you talk about kind of breaking up fascial adhesions with foam rolling. So this is a little bit unrelated to foam rolling specifically, but how much validity is there to this idea of fascial adhesions causing, discomfort, pain, pathological movement? How do those work, and do any of the manual therapies actually address those, like Graston or things like that?
Yeah, that's a really good question, and I don't think anyone that I've found has great answers on it. But here's how I'm thinking it through. The fascial adhesion type of notion, if there are fascial adhesions, and if we do break them up, why do they keep forming? If it's going to work, it should work and be done. You should break the adhesion, and there we go. If there is a pathology that's going in that we could break those adhesions and they do come back, that seems to be the bigger issue. Why do they keep coming back? So I am very, very, very skeptical that we can palpate and break adhesions. If you just look at a cross-sectional dissection of anyone's arm or thigh, the layers of dermis before we get to fascia and all that tissue, I mean, we can barely deform superficial scar, with our hands. And the strength of that is huge. And if we could impart that strength, could we really tolerate that type of pain? Would the skin be able to actually do that? The depths of penetration of our fingers to tissue that we're talking about, like, oh, we're digging into the piriformis, like, no pun intended, but my ass you are, like, you're like, that's like putting a piece of steak on the table and putting your thumb on it and tell me what type of, texture the table feels like, So that's not to, by the way, negate the effect of these manual therapies, but I think what is more likely to be happening is, again, the most neurologically dense tissue in the body is our skin. The amount of afference that we could stimulate through just manual touch could be huge. And so I am very skeptical of the mechanical effects of manipulating tissue. But the biggest question I can't get answered is, if we could break that up with our hands, why do we have to keep doing it? And I haven't found a good answer for that.
Yeah. So a couple follow-up questions is, one, and this is maybe more of a comment than a question, but so I have quite a few friends of mine who've done like cadaver lab, weeks where they go and they like kind of do big cadaver lab studies and look at anatomy and things like that and talk about, what the fascial tissue looks like and all that stuff. What is your kind of view on that tissue itself in the body? Like, what is its role? What are some of the like misconceptions that you think a lot of people have about it?
It seems like its role is to help transfer tension passively, and it seems like it's incredibly strong. So that's the most I know about it. What its metabolism is, what its response to load, what its response to transverse force versus compressive force. It's very hard to study because many argue that it behaves differently, in vivo versus in vitro. So I think that's where the biggest problems are. People are looking at cadaver studies and they're like, well, that tissue is not even close to similar to how it is when we have a living, breathing body. So I think there was a study that came out that did show some ability of seeing that there was fluid that did pass through layers of fascia, giving it a notion that it's a more dynamic tissue than we thought. But I think that's the bigger thing that I'm learning about, is that it seems like its main thing is transferring force passively, and it's incredibly strong.
So then the other question is, I've spent a fair share of my time in a PT clinic in my life. And one of the things that's probably the last 5 to 10 years, every time I go in there, it's kind of been regardless of what issue I've had, is there's always been some level of like Graston used. I guess, one, what is that actually doing? Because I always leave, with huge amounts of petechiae and bruising and things like that. And, it's one of those things where it hurts, but it feels good at the same time. So, what exactly is kind of the actual mechanism behind it? And, how much do you employ that kind of at your clinic, and kind of what's your thoughts on where that fits in a treatment protocol?
Yeah, another great question. We actually just had an in-service from one of our clinicians on that. I try to get our younger clinicians to present on that, because I think I know with myself and older clinicians that have been practicing before, those were readily available tools have an inherent bias to it. Manual therapist, it can sometimes be old school. Like, I got to use my hands. Why do I need some instrument? It's another layer between myself and the patient, and say, how can I assess the different tissue quality, all that. So I think I have a bias on that. So I'm trying to learn about what the mechanism is. And I have just been routinely disappointed. And the explanations, they don't make sense. I'm trying to understand it more. I'm trying to get what the mechanism is. But to me, and this is coming from somebody, ironically, about my bias, is that, my undergraduate degree is in biomechanics. I don't see the mechanical effect here. I see it as more of a neurological effect. And in soft tissue in general, I mean, I just can't imagine how you can use a butter knife looking tissue and be able to penetrate deep into the middle layers of your quad, whether only being able to manipulate the superficial layers are effective. That being said, I don't see a whole lot of harm in it. I do see people getting some good results from it, more willing to stretch, more willing to move. So it's hard for me to say, I wouldn't do it. It's harmful. Stay away from it. It's bogus. I just think the evidence behind it is relatively weak. But my criterion for having strong evidence on it is relatively low, because I don't see a huge negative or downside with it too. But my overall idea on it is that I haven't used it much, because I haven't found that there's been a need where I can't get somebody better by using the, other soft tissue mechanisms, or simply movement or load management.
Very interesting.
It really is.
Yeah, it's one of those things where and this is, I think, one of the hard parts about kind of the physical therapy field is it's one of those things where you're really balancing like psychological pieces that are very hard to measure. I think that's like one of the hard parts about that research is,
right,
like, how do you have a definable hard outcome for a psychological effect, right? That's one thing. And then the other thing is, it's probably very difficult to get like standardized research done, because not all patients are the same.
right.
And a lot of these injury problems are multifactorial, and not everything has the exact same etiology. So it's a very interesting kind of area of research that I think is, the answers are very hard to come by, like the hard answers.
I can tell you an interesting phenomenon that I've found is that the people that tend to tell me that they've done well with Graston are people that came asking for it.
Yeah.
And again, I don't think that's a negative. It's the same thing. I do spinal manipulation very rarely, but that is something people are asking for. They have come in with a positive expectation of it. So, I think there's a huge part of that. And I don't minimize or trivialize that or critique people of it, unless it's completely inappropriate, or it gets in the way of much more important type of treatment. So I try to keep an open mind on it, but I'm frustrated by looking at the answers that you're asking for, which I think are great ones, which is what's the mechanism and what's its relative efficacy compared to other type of treatments. We just don't have a strong answer for that yet.
Yeah. Perfect. Well, I think we covered all of the topics that we set out to today. Any other kind of last minute thoughts on either of these topics before I let you get back to your day?
Yeah, just real quick. I think, it's always good to investigate these things, and it's always great to look at them. But I always tell people, before you formulate your question, should I use foam rolling for me? Should I use, various, soft tissue, interventions for me? Categorize them, in the big picture. I think we get ourselves in the weeds. I do it definitely as a clinician, of arguing about the specific mechanisms of this, but put it in the general picture. We know we need to be moving, and we know we need to load. We know pain is a complex phenomenon, and it's experienced differently by people. Don't get too drawn out on the specific nuances of it, because sometimes I think we lose the big picture. It's kind of like how you've heard this about nutrition, right? Nutritionists will argue about 5 or 10% of the things, but they agree on 90%.
Yeah.
Whenever you get to something like this conversation about foam rolling, you hear Mike Boyle say this, and then you hear Greg Lehman say that, and who do I listen to? Just keep in mind that it's probably not that big of your training or health, that big of an issue. Always go back to focusing on the main points.
Beautiful. Awesome. Well, Mike, thanks so much for your time and for jumping on with us today. I will shame Jay for not being here today. So
yes,
we'll see you in a couple weeks, I guess.
Yeah, that sounds good, man. Good talking to you again.
Awesome. Appreciate it.
You got it.